Thank you very much, and I'm sorry I don't speak Latvian. I feel very ashamed that I'm doing this in English and can't talk in Latvian to you. So my name's Rosie. I'm a doctor by background, and I've been working in patient safety for several years. And I just wanted to talk about some of the work we're doing in England around patient safety to look at how we're improving the care for people there. So as the previous speaker said, actually most people coming into health and care come in every day to do a good job. They want the best care for their patients, but sometimes things do go wrong, and often it's related to the environment, the systems, the processes that they're working in, and it's not usually because they're bad people. Now, you might have heard in England we have had a bad person recently. We sadly have had a neonatal nurse called Lucy Letby who has made us all kind of think very carefully about patient safety and how that could have been picked up sooner. But the vast majority of people come to work every day to do a good job. And you've probably all seen this report, which is now over 20 years old, To Err is Human, which talked about the importance of a different culture and a different way of looking at patient safety. Just to give you a bit of context, we have a big problem in England, but this is an international problem with patient safety. So in England, we have almost 6,000 patients a year that have serious life-changing harm. I find that staggering, but I think that is replicated from what I can gather in every country in the world. We actually spend a huge amount on litigation in England, and we find that we actually spend more on our litigation for maternity services and to people who have had a poor experience in maternity than we actually do on providing those maternity services in England. We know that in England alone we have 237 million medication errors a year, it's predicted. Now, we have a population of about 66 million. So it's an enormous problem, and we have 181,000 bed days used. So 181,000 days of people being in hospital because of medication errors alone, and that doesn't account for other errors. So it's an enormous problem, and we're all trying to think about different ways to solve it. The other thing we've talked about a lot this morning is around health and care professionals, and I know most people across the world are struggling with workforce retention, recruitment, workforce shortages. And actually, when something goes wrong, it's really impactful for the health and care professional that's involved in that care. Often they go off sick because if something's really gone badly wrong, it causes them a huge amount of stress and anxiety. They feel very guilty, and sometimes we find that they leave the profession early as well. And clearly we need to be working with our health and care workers and making sure that they are supported and that they get the environment to be able to deliver their care properly. So I just want to tell you a little bit about the organisation I lead, which is called the Healthcare Safety Investigation Branch. And we were built on the model from aviation, so built on the Air Accident Investigation Branch, which has been in existence for about 100 years and investigated accidents when planes crash. And there's an international network of air accident investigation that means that actually within a few minutes, if something happens on an aeroplane in the UK, within a few minutes, all of those planes across the world can be grounded. And I find that amazing, and I think we've got to get to that position in health, but we're a long way away from that at the moment. I'm not going to compare healthcare to aviation. I think healthcare is far more complex in a lot of ways, and I'm not in any way suggesting they're the same. But I think underpinning what we do and what the Air Accident Investigation Branch do and other similar bodies is that we use safety science, we use human factors understanding to really understand what has gone wrong, and then make sure we extract that learning into the national system so that we can change policy, change guidance, change ways of working so that those things don't happen again. As we've heard, it's really important that we don't apportion blame or liability, and that's very much our ethos as well. We look at actually supporting healthcare professionals, enabling them to speak up openly about what's happened, because unless they're able to speak openly, we're never going to find out what's gone wrong. We focus on the things that we can change at a policy level. So our recommendations go into the system, into a national level, and I'll talk about who we make recommendations to in a moment. But we find that often it is those systems and processes that are affected by national policy that can make the difference. And we're also keen to professionalise the patient safety investigator role. We know that I don't know what the system is here, but in England we have lots of people doing local investigations when things go wrong. Often they're doing it on top of their day job. Often they're not trained, they don't have necessarily the right skills, and we want to improve that, and we have a big education programme which is available for everyone to access, so that's something that if you wanted to know more we could talk about. And my team comes from a whole range of different safety critical industries, so we learn from the other industries. We learn from aviation, we learn from the nuclear industry, we learn from engineering, from military, and my team cover all of those specialties. Importantly, we involve patients in those investigations. Often when you talk to patients who've been harmed, they say sometimes the investigation can compound that harm because they're not involved well after the event. And we think it's really important that we involve people who have been harmed in those investigations, and it's part of that kind of restorative healing that can actually help them. So, we do about 20 to 30 investigations a year, and those investigations we really try and look at the biggest patient safety risks. And if you, at the moment, we're looking at urgent and emergency care, we're looking at palliative care, we're looking at mental health inpatient units, we're looking at workforce and patient safety, and a whole range of other areas as well. Just to note, we've also got a maternity investigations programme, which I won't go into too much detail here, but we do about up to 1,000 investigations a year on mums who've had a stillbirth, maternal deaths, on babies with brain injury. So that's another programme that we run, but they're very individual investigations, and that programme is quite different. So this is a busy slide, but essentially we work with all of the stakeholders across the country to identify where are the biggest patient safety risks and where can we add the most value. We then bring in expert advisors, we bring in clinicians, we bring in safety science experts, we bring in people with lived experience, and then we use all of that information to then undertake an investigation across multiple hospitals, multiple primary care providers, multiple sites where people are experiencing care. And then we make recommendations to lots of bodies. We make recommendations to the government, we make recommendations to royal colleges, to NHS England, who's the main commissioner in England, and also to regulators. And those organisations have 3 months to respond to us in terms of what they're going to do about those recommendations. And that's all set out in law. And we also investigate what happens between a lot of those different providers. We find that often patient safety falls down between a hospital and an ambulance, or between a hospital and a GP practice. And actually how those organisations all work together across a pathway is really important. So we investigate right across a patient's journey through the health and care system. And we've seen over the last few years already quite a lot of positive impacts from our work. For example, we've got new guidance around aortic dissection. All engineers looking at hospital oxygen need to be accredited now. I mean, we cover a whole range of different areas, including supply chain, procurement, estates, clinical aspects. We know that outpatients, we've done a lot of work about how people are seen in outpatients departments in hospitals. We've also, for example, been looking at medication safety in paediatrics, and we've seen examples of where all of that care has improved through the work that we've done. just to say, and I'm very excited because on Sunday we are setting up as a new independent body which is going to change its name. It's been set up as the Healthcare Safety Service Safety Investigation Body, and that's enshrined in law, and we're going to be a fully independent body from the government, funded nationally. And I think that will give us a really good opportunity to actually then have a strong voice for safety and to be able to say difficult things to government, say difficult things to all parts of the system in an independent way, which I think is really important. The final thing I just want to touch on is a report that we're going to be talking about in the next month or so around safety management systems. Now, I don't know how many of you know about the concept of safety management systems here. Again, it's something that we're learning from other industries. And actually, if you talk to someone who works in the nuclear industry or talk to an engineer, all of those processes have got what's called a safety management system behind them, and it's a much more proactive way about identifying risk. We often find in health what happens is we identify problems after they've happened. You know, one of my team slightly glibly says, actually, it shouldn't be first do no harm, it's first do some harm, because actually what we find is that unless something happens and something goes wrong, we don't take much notice of it. We think there needs to be a much more proactive approach where people identify hazards long before they become a problem. So we've been talking to a whole variety of different organisations. We've been talking to NASA, we've been talking to the Navy, we've been talking to aviation, we've been talking to a whole variety of different industries to say, how do you manage safety and what can we learn in healthcare? And if you'll just bear with me, I've got a 3-minute video just to explain what a safety management system is. And this is something that we're exploring. It's at very early stage, but we think we need a different approach to healthcare when it comes to safety, and we want to explore this further. So I'm hoping this works.
Those who work in health and care are keenly aware of the need to identify and manage risks to protect patients from harm. But we aren't the only industry that must take safety seriously. Is there anything to be learnt from comparing notes with other safety-conscious industries? To find out, we interviewed experts across all sorts of safety-orientated roles, those in health and care, but also those in oil and gas, shipping, aviation, rail, road, nuclear, and NASA, on a mission to understand their approaches to safety management. In these fields, systems for organising and coordinating safety are often called safety management systems, or SMSs. There's no one-size-fits-all SMS, but they share 5 core ingredients. First, identifying potential hazards. Secondly, managing known risks, assessing and prioritising them. Third, monitoring safety performance, questioning how real-life outcomes compare to expected levels. Fourth, handling change effectively, quickly catching unintended consequences. Fifth and finally, promoting safety, giving everyone the tools to manage safety and driving home the mindset that this is a shared responsibility. Across the board, interviewees stressed the importance of well-coordinated leadership to secure buy-in and weave an SMS into the organisation's fabric. A distinguishing attribute of SMSs is that they are proactive. It's about managing risk before harm occurs and assuring processes to be certain that they are safe. Responsibility should be clearly defined at an individual and organisational level, looking beyond one person, team or site in silos and considering the entire industry as a single system. So then, turning our thoughts back to the world of health and care, should we rethink how we work together, learning from the SMS approach? Health and care workers told us that although their processes have much in common with an SMS, ongoing safety risk persists because change is difficult. A change might be made to, say, introduce remote consultations and virtual wards, but then who is responsible for assuring the safety of these wards? Hundreds of interconnected organisations and over 1 million employees make up the NHS, with a complex landscape of stakeholders on top of that. Action taken in one area can have countless knock-on effects elsewhere. For example, discharging patients to social care may free up beds, but can they then access appropriate care, or are they put at further risk? There are clearly no quick fixes. We need to assess levels of safety maturity, understand the accountability framework the health and care system needs, and promote the principles of safety management. The safety management system approach could help the health and care sector better manage risks before harm occurs, delivering safer levels of care. For further information about this work, visit the HSSIB website.
Thank you very much, and I'll end there, but please, if there's any questions, I'd be very happy to answer them. Thank you.